Hello, everybody, and welcome to our first part one lecture for this week of October 6th. When you remember in our intro class, I talked about that we would be, over the next course, several weeks, we will be doing the regulations online, and I will also be providing discussion questions for you to work on that will relate to the lecture material. One of the things that we are going to do also is this week, October 6th, and next week, October 13th, will just be taped lectures. The week of October 20th, we will actually do an online chat session, and I will post that. We'll do that through GoToMeeting. And if somehow you would not be able to make it, I will record the chat session so you can follow along. And the goal of the next couple weeks is to introduce you to a different part of the profession, and that is long term care pharmacy, but also to help build your skills as a clinical pharmacist. Because another area for job opportunities is in consulting pharmacy. And in fact, consulting pharmacy is one of the only places that pharmacists, it is required that they have to be paid for their clinical services, and is a Medicare required law. So what we're going to do is I broke up every week. These lectures can be, because it's a 3 hour course, long. So what I did was, for this week's lecture, I broke them up into two parts. And so today I will be posting, and you will have found it on Blackboard, the Intro to Long-Term Care Part 1. Later this week, excuse me, later this week, I will be posting um, the part two lecture, which will actually go into the regulation, and we'll be doing talking about some examples of how you would review a case. So let's begin. Long-term care statistics. One of the things I talked about when we talked about different types of housing is that there are many needs for people requiring institutional care. That can be medical needs, it can be psychological needs that they're unable to care for themselves, and it can be social needs that they do not have anybody who cares for themselves. If you remember in that first week lecture, I discussed um, the difference between personal care home assisted living with skilled nursing care. And skilled nursing care is those traditional nursing homes that you have probably been familiar with. And traditional skilled nursing homes require 24-hour nursing, and usually the people that are in these skilled nursing homes um, are dependent upon at least 2 to 3 activities of daily living, which could be bathing, toileting, feeding themselves, being able to dress themselves. When you look at personal care homes and assisted living, people still may have a deficiency in activities of daily living, but where their deficiencies usually lie is within the instrumental activities of daily living, such as being able to manage a checkbook, being able to shop for themselves, being able to cook for themselves, being able to manage their own medications. And although the biggest growth in the industry has been in personal care homes and assisted living, the regulations and rules and requirements have been really dependent upon state laws, not federal laws. So what we're going to talk about over the next couple weeks will be laws reflecting skilled nursing homes, and these laws are regulated by the Center for Medicare and Medicaid Services, but these laws are also sometimes implemented when states look at developing laws for personal care homes and assisted living. And so we will highlight those based on the state of Pennsylvania. I'll try to highlight some of them of various different states have been a little bit more proactive in the personal care home and assisted living, which, depending upon where you practice in the state, that personal care home and assisted living may require a pharmacist also to be participating in their medication management. As I said before, there's numerous different types of classifications of long-term care facilities. Those can include your traditional nursing homes, which I just talked about, and a lot of times those nursing homes may have specialized care units for dementia patients. Nursing homes also have subacute care units because under Medicare law, all individuals who are eligible for Medicare Part A are all also eligible for 100 days of skilled nursing care. That means that, for example, say you break your hip and you go to the hospital, but you can't go home and you require rehab, you may qualify to go to a skilled nursing facility for a length of time. And that length of time for most people that go into skilled nursing home is anywhere from 14 to 21 days per admission, but that's only good for up to 100 days of your life for skilled care. Now, we will talk a little bit about the economics of that later down the road, because when nursing homes take Medicare Part A patients, they are required to also be responsible for paying for their medications, because these patients are sort of handled just like you would in a hospital, that the home is getting paid a per diem per day based on that patient's condition to take care of them. And why that is important to you as a pharmacist, that a lot of times consulting pharmacists get involved in helping to control costs through formulary management, through therapeutic substitution algorithms for that nursing home. There's other areas of care. There's immediate care for those with mental retardation. There's respite care, assisted living, independent living, hospice care, and also correctional facilities. Most closed-door long-term care pharmacies will take care of these type of individuals. And what's the requirements of a long-term care facility requiring pharmaceutical services? Those are the dispensing of the product, the delivering of the product, because most nursing homes do not have a pharmacy on site, and so they need to have a way for those medications to be delivered. And usually, if it's a skilled nursing home, they require at least twice a day delivery, possibly. And if it's a personal care home, assisted living, it's usually once a day. And also, they need possibly emergency services in case there's an acute med that they need very quickly. The other thing that pharmacy is responsible is helping that nursing home take care of their medication administration records, their documentation. We have now entered the era of paperless documentation through electronic health records. We're also looking at pharmacies that also help oversee the appropriate storage of these medications, making sure nursing and nursing staff knows how to handle these drugs in terms of storing them and administering them. As I said before, record keeping. You do get involved with third-party insurances. You do get involved possibly with formulary management, especially for Medicare Part A, subacute care patients in skilled nursing facilities. And you're also providing clinical services, because as you've learned over the last couple of weeks about functional problems related to geriatrics, that is an ever constant need for a pharmacist to be involved. As I said before, pharmacy services are categorized as distributive and clinical. In fact, not here in Pennsylvania. Most pharmacies that provide distributive services to nursing homes also provide the clinical services. But in several different states across the country, they actually look at that as a conflict of interest, and so that it's required that the clinical services be a separate company, excuse me, from the distributive services. And so, for example, in the state of New Jersey, long-term care pharmacies do exist, and they help distribute the drugs, but there's also been a rise over the last 20 years of clinical consulting businesses to help with that. The state of Tennessee also has something similar to that. And like I said, both are essential in ensuring a high quality of patient care. And even though you may be the clinical consulting pharmacist, you also a lot of times are the representative for that pharmacy, or the communication piece for that pharmacy providing distributive services. And if there's a problem, it's usually your responsibility to make sure that problem is resolved, or communicate that problem to the distributive pharmacy. So constantly there needs to be communication between the consulting pharmacist and the pharmacist in charge of dispensing and processing the drug products. Like I said, long-term care pharmacy a lot of times is a closed-door pharmacy, very similar to the hospital. When you think of long-term care pharmacy, it's kind of a hybrid between long-term care pharmacy and like a hospital and community pharmacy, because depending upon the rules and regulations of which type of home, whether it's a skilled home or a personal care, those rules are a little bit different. In fact, in the eyes of the federal government, only true skilled nursing homes are considered institutional care, where personal care homes, assisted living are, in the eyes of the federal government, considered ambulatory care. Now, those rules may differ in states on how the state looks at that, but on a federal level, in terms of reimbursement, that plays a role. The other thing, those who are into long-term care pharmacy, you have chain type of long-term care pharmacy, such as the largest chain in America, known as Omnicare, and then you have independent closed-door pharmacies that can run from closed door pharmacies taking care of maybe several nursing homes, and in the nursing home industry we refer to how much business you have to how many beds do you take care of. And so the average long-term care pharmacy may take care of 1,000 beds, but here in the state of Pennsylvania we have a very large independent long-term care pharmacy that actually services several states, and that's Diamond Pharmacy, located in Indiana, Pennsylvania. Just some nursing home statistics. Like I said, there is close to about 1.5 million facilities. The average facility houses anywhere from 88 to 100 residents. In the state of Pennsylvania, we have close to about 800 facilities, and that average facility is about 109 residents. Now, one of the things that we're going to talk about consulting, but that's kind of fascinating, that every year the American Society of Consulting Pharmacists publishes some statistics about how much time pharmacists are spending consulting clinical charts. And one of the statistics that's kind of interesting, it's like 9 minutes chart. So if you look at, you had 109 residents, that's about 16.4 hours. And what we're going to do in the next lecture is we're going to go through an example of a nursing home case. And actually, I'm going to publish that nursing home case ahead of time before the second lecture for the review. And if you can actually do that whole review in 9 minutes, I'll let you pass the course right away. But in reality, true consulting time, it takes about maybe 20 minutes to 30 minutes to work up a new patient. And for a patient that you see, because you have to review the charts on a monthly basis, that may be anywhere from 15 minutes. So true consulting time for a home of about 109 residents would maybe be about 30 hours plus 4 hours of reports that you are required to do and meetings, which we'll talk about reporting in a later lecture. The other thing too is when you look at who's actually paying for nursing home care, Medicare patients plays a big role, and a lot of times those Medicare patients are Part A patients, and so these are patients that are turning over, they're not staying there long. And then the biggest player in long-term care is Medicaid. Most patients, to be able to afford nursing home care for life, near the end of their life when they do get admitted, usually will spend down their assets, and eventually they will qualify from an income status for Medicaid. There are also private payers, and in your lifetime you'll be entering where people have purchased long-term care insurance, and so we really haven't seen a growth in that because we haven't reached the population age that actually has done that. The other big thing that you become if you are a consulting pharmacist is that if you don't like psych, well, you don't have a choice. You are responsible for a lot of psychoactive medications because we are dealing with patients that they have a high incidence of depression. We're dealing with patients with a higher incidence of dementia, and a lot of times we're taking care of psychological and behavioral issues, which may include antipsychotics and hypnotics and anti-anxiety medications. And although these may help, they can also provide a lot of complications, and so the ultimate goal is to try to use them as a minimum to keep safety. And so you will constantly be, as I like to say, the psych police in a nursing home. And next week when we talk about unnecessary medications, we'll go into that in a little bit more detail. The other thing too is, facilities, and I'll just focus on PA, but it's very similar in statistics. For-profit does exist, so does nonprofit, and the VA also participates in the nursing home industry. When you look at terms of direct care, all right, there is, depending upon numerous different type of staff members, and you see registered nurses, licensed practitioner nurses, aides, and then also in the nursing home facilities you'll see physicians that are taking care of these patients, but a lot of these physicians have physician assistants or nurse practitioners that you'll be working with interprofessionally to provide care for that patient. The other thing is what type of disease states. Well, pretty much the disease states that you see in chronic care of all type of adults, which is cardiovascular, but some of the key ones you'll see is heart failure, diabetes, dementia, pain management, urinary tract infections, incontinence, osteoporosis, and wound care. And although you'll also come across other disease states, these are key ones that you want to become an expert at, and being the expert in the pharmacological management for these disease states. And also understand the problems that go along with these medications in terms of geriatric care. When you look at the distribution and service role for long-term care pharmacy, a lot of long-term care pharmacies, the traditional prescription valve doesn't cut it. So you need dispensing services for packaging. And so packaging can go from anywhere from bubble packing to multi-dose packing, which you'll see on the right. And so these are usually have become automated, but one of the roles of that nursing home pharmacy is to make sure that these medications are packaged appropriately, that they'll not be broken down from an integrity standpoint, and also why they are packaged so that there's accountability, that we are tracking that nursing is actually giving it, and also to prevent theft from possibly occurring. I love this formula because this formula really helps focus, and I use this formula in other areas outside of long-term care, but this formula was originally created by the experts in long-term care, the American Society of Consulting Pharmacy. And the total drug cost is looking at, you have a drug and it costs X amount of money. It also costs X amount of money to package it, especially in that special packaging, the amount of tech time that goes along, and also the delivery costs. But one of the things in nursing homes is, and I always tell this to nursing homes who are paying for medications, especially if they take care of Part A patients, is utilization. That if we don't use the right drug for the right person at the right time, there's cost to that. And because we don't use the right drug, we may see therapeutic failures, which require them to maybe stay longer, or we may have to use other multiple medications because the first ones didn't work. And also there's risk for adverse reactions. And also if adverse drug reactions occur, there are problems, and now there are penalties occurring if we're not doing value-based care. So one of the things too is when we do the discussion session in 2 weeks, I will ask you guys some questions about how you see examples of this. So we will go into more detail of this as we progress. So how do we control drug costs for the product side of the formula? One of the things that closed-door pharmacies can do is they can do what's called contract pricing. By being a closed-door pharmacy, you may get better deals on especially brand medications than you would in a traditional community pharmacy setting. Obviously, trying to utilize generic drugs to save money. Also, long-term care pharmacies also may have the opportunity to get rebates for using appropriate different products. Because it's an institutional setting, you can actually create therapeutic formularies for your Medicare Part A patients. You can do therapeutic interchanges. For example, you may have the statin of choice that you would substitute, or the PPI of choice to help control cost. And then the other thing is physician education, making sure they understand what are the better medications to use that are going to be clinically effective and also cost effective. Distribution costs. One of the ways closed-door pharmacies may be able to help control distribution is through automation. Several of the larger long-term care companies have actually put Pyxis machines, Omnicell machines in the nursing home so they actually can dispense on site, and that might help control waste, especially if somebody isn't there for a long period of time. And so robotics, technicians, unit dose packaging is ways to help control costs. The other ways to control costs is now we see physician order entry in long-term care facilities, and we also see paperless systems using electronic medical health records. So let me just give you a little brief on the history of consulting pharmacy. Not to bore you, but just to kind of show you where we've come from and where we are today. So in 1965, when the Medicare and Medicaid Act was passed, it was seen at that time that a good chunk of where the funds would be used is what would be in skilled nursing care. And so during that time was passed in 1965 that a pharmacist should be involved in reviewing clinical charts in a nursing home. And a lot of this probably had to do with the administration at the time, the Johnson administration. The vice president was Hubert Humphrey, who was he was a pharmacist by trait, and so there was a big push. But at that time, we were really more of in the distribution role, and we were known as what called paper consultants. We were overseeing maybe major drug interactions, things like that, but we really weren't doing chart review. In 1974, the standards changed. It felt that there needed to be more involvement within pharmacy, so it was mandated that pharmacists must review the drug regimen per month. And so we first saw pharmacists spending time in the facilities. In 1980, it was looked at that was these pharmacists actually, even though they were going to these facilities, doing what they said they would be doing and providing decreased problems with medications. And so what they did was in that time they published which was called the creation of the Appendix N. And the Appendix N basically gave an outline of things the pharmacist should be looking at. So those are classic things we teach you today from a clinical standpoint, looking at things such as therapeutic failure, looking at, whether or not if somebody's on Coumadin, are they getting their INR checked, somebody's on a diuretic, are they getting their potassium checked. Clinical standards that you guys are taught every day were being pushed here in this Appendix N. So a couple of things that were outlined in this Appendix N that reviews needed, that everybody needed a chart review. So whatever the average census was, it better be that that pharmacist was reviewing all those charts. The other thing it required that the pharmacist needed to be at the facility X amount of hours to review that, and they had to sign off in the chart that they did review it. The other thing is they wanted to look at whether or not patients who were on 9 or more medications were taking those medications appropriately, and that was just an arbitrary number at the time. We've since gotten rid of trying to classify 9 or more meds, because if you think about a patient, if a patient had congestive heart failure, diabetes, COPD, and those patients are probably going to be on 9 or more meds because it takes about 2 or 3 meds per disease state to treat them. But during the time in 1982, we had less medications to treat those diseases. And so 9 or more meds was a way to look at, were they on the right drugs? One of the things I will teach you over the next couple of weeks is, are the patients on the right drug, and do they have an indication for that medication? And if they don't, we need to get rid of that medication. One of our jobs in long-term care consulting pharmacy is to identify possible problems that are occurring right now, identify possible future problems with medications that could be problematic, such as the Beers criteria medications, and also identify any drugs we may be able to get rid of. In 1984, they actually updated the survey procedure, and what they did was they began what's called medication pass observation. One of the responsibilities a pharmacist has is that they will oversee every once in a while how a nurse is passing the meds. Are they administering them appropriately? Are they using appropriate inhaler technique? Are they administering insulin pens appropriately? Are they documenting appropriately that they gave the medication? Because when a nursing home is surveyed, that is one of the things the surveyor will do. They will go on several different med passes and look at what is the potential for med error from those nurses. 1986 was the first time we actually saw an article published showing that consulting clinical pharmacists in nursing homes saved nursing homes, millions of dollars by doing high quality drug regimen reviews. In 1986, the Healthcare Finance Administration, which is now known as CMS, published the ways that, surveys should be conducted by Medicare in the nursing home. We'll talk about surveys later on in the course, but in 1986 was the very first time this was passed, and then also put in the requirements for pharmacists to help with medication pass outcome-based evaluations, which we will also discuss later on in future lectures. 1987 was the Omnibus Budget Reconciliation Act, and this actually put several amendments to the pharmacy practice in nursing homes. And this was the very first time that it started stating that previously the facility was only required to have a pharmacist report findings regarding an individual patient medication irregularities. Now they wanted to look at, the pharmacist had to look at trends. What is the nursing home's usage of psychotropic medications? Are they being used appropriately? Are they being monitored appropriately? 1987, the Omnibus Reconciliation Act, like I said, focused on the use of unnecessary drugs, and mainly those were antipsychotic medications, IV medications like antipsychotics that were giving IM or IV, and like benzodiazepines, Ativan's used IV, and they looked at the quality care of that. So 1987, pharmaceutical services was expected to be carried out, and that nursing home had to have what's called a quality assessment assurance committee, and the pharmacist does play a role on that. And so the role of the pharmacist consulting, had a big emphasis on the optimization of medication use. The other thing that occurred in 1987 was they require these nursing homes to look at doing good resident assessment, doing good care planning for the resident, and what was the needs medically and psychologically for each resident. And so one of the things that we get involved in long-term care is helping nursing meet those requirements for each resident when it regards to medications, whether using medications to help with that or remove medications that may be causing harm to them. 1995 was the final rule of OBRA 87, and like I said, it put a big role on us in helping with behavioral management, being able to review and look at dose reduction in antipsychotic usage, and it also had specific requirements for physicians and facilities seeking to justify the use of the drugs they are and the length of time that they're using them. The other thing that was included, antidepressants are now included in discussion, and those were also looked at, to make sure that patients were being appropriately monitored. The other thing, it was required that the medical director gets a copy of those reports, and in today's world, that medical director is required that those reports are acted upon by the physician, whether they agree with your recommendations or not. In 1996, there was required by the federal law what's called the minimum data set, and this is the assessment set. And we'll go into detail this more because it's now updated. 5 years ago, it was updated to MDS 3.0, and this is a way that when you go into a nursing home and you're looking at the chart. One of the things we'll talk about charts in nursing homes, they're not great. A lot of times there's a lot of information lacking, but what the MDS does, it gives you a little snapshot of exactly what are all the conditions of the patient, what are all the medical needs of the patient, what are all the physical and psychological issues with that patient, so that you can look at what's the best way to care for that patient. 1999, there was additional indicators, and one of the things those indicators looked at was the Beers criteria for the very first time, and looking at whether or not patients were on Beers criteria drugs and were they affecting their quality of life. Also in 1999, you saw 24 quality indicators that are used to help with nursing home facility surveying. And they cover several different areas, and we'll go into a detailed lecture about these areas. But they look at everything from accidents to cognitive behaviors to incontinence to infection control to wound care. And if you look down all those different indicators listed here, all of those can be maybe managed by medications, but also medications may cause harm. So, for example, somebody has a medication that causes orthostatic hypotension, the patient gets dizzy, they fall, and then they actually have a fracture. Somebody's on a medication that may cause urinary retention, therefore a UTI occurs. So these quality indicators we are constantly involved in as a consulting pharmacist to make sure nursing is getting able to achieve these. And one of the things that nursing does is they compare their quality indicators against the state level and the federal level to see where they rank. So 5 of the 24 quality indicators directly involve medication use, and those include things such as prevalence of symptoms of depression without drug therapy, prevalence of residents who take 9 or more medications, prevalence of antipsychotic use, prevalence of antipsychotic hypnotic use, and prevalence of Beers criteria drugs. In 2004, we saw the elimination of the Appendix N, and now in 2006, which it was several years ago, almost a decade ago, we saw an update. And what we constantly are referred to in the Federal Register by Center for Medicare and Medicaid Services, they list these tagged regulations of what nursing homes have to follow. If they, on a survey, don't meet those regulations, or there is shown possible harm to the residents, these nursing homes usually have to make a plan of correction, and they could be fined by Medicare up to $10,000 per day. And the biggest thing is, depending upon the fine, if you take a look at this slide, they have to figure out a way to correct things. All right. So, for example, I had a nursing home a couple years ago who didn't have a good way to how to manage a patient who's refusing their medications. They didn't have a good way to possibly take care of patients who had an increased risk of falls. So they sometimes they will get fined. Sometimes the worst case scenario they could be shut down, or they could have restrictions on new admissions. Which, if the other thing I didn't mention before, the average life of a nursing home resident is about 2 years, 2 to 2.5 years. And so this can have a major financial impact on that nursing home. One of the things too is when a nursing home gets surveyed, not only do they get surveyed by the Center for Medicaid Services (CMS), but the Department of Health and Human Services for that state works with Medicare in helping with the survey process and renewing their skilled nursing homes are regulated by the Department of Health of that state and Center for Medicaid Services, and they usually jointly will do a survey together. So what happened in 2006? We saw these F tags combined. And so what we're going to talk about in part two of this week's lecture and in part three and four of the coming lectures, we're going to talk about these different F tags. So we are going to talk about in my second lecture that I'll be posting actually by Thursday this week, F tag 428. And F tag 428 looks at how do you actually do a medication regimen review. What are the requirements for that? Next week we're going to review F tag 329 about unnecessary drugs, and then the following weeks we'll review F tag 425 and 431. So just to summarize, this first part one lecture reviewed the history of long-term care and the opportunities that you have in consulting pharmacy. And if you do have an interest in learning more about consulting pharmacy and the opportunities, I'd encourage you to talk to any of your students, colleagues who are involved in our student chapter for the American Society of Consulting Pharmacists. They do have a student membership, and they provide some good material for that. Another good place to learn about long-term care pharmacy is NCPA, National Community Pharmacy Association, has on their website a lot of information also about long-term care pharmacy. And so what we will be talking about in part two lecture, we'll be talking about the drug regimen. The drug regimen of each resident, as I said before, has to be reviewed at least once a month by a licensed pharmacist. And that pharmacist has to identify any irregularities, drug-related problems, to the attending physician and the director of nursing. And then is what also is requirement that these reports need to be acted upon. That physician may not agree with your recommendation, but if they don't agree with your recommendation, they have to provide good, good documentation of why they don't. So, one of the things I'd like you to do before I post the second lecture, which will be on Thursday, is to review the nursing home case I posted, the sample nursing home case. And what I would like you to do is start looking at that case and seeing a couple things. One of the things when I first look at a patient case, I look at the drug regimen, I look at the problem list, and I do a matching game. And I say, does every drug have an indication? Then the next thing I think about is, what do I have to do to monitor if there's anything going wrong with these medications with that patient? What do I have to monitor to make sure these medications are working? So what do I have to monitor for efficacy? What do I have to monitor for adverse drug reactions? And so please take a look at that case. We'll kind of just highlight a little bit on the part two lecture about this case. And next week when we go through unnecessary medications, I'm going to let you use that case to identify unnecessary medications. Thank you very much, and I will talk to you in the next lecture.